Good morning and welcome to Grand Rounds this morning. It is my distinct pleasure to introduce Dr. Eric Coon today, who's come to us from Seattle. Dr. Coon is a professor of pediatrics at Seattle Children's, previously at Utah, made a move recently. And he's going to share some of his journey and his work. He's done some really exciting work in pediatric hospital medicine, building up the evidence through really amazing RCTs, asking solid questions about how we deliver care to patients. I assume he will be speaking today about his benefit trial, looking at follow-up for patients who are hospitalized with bronchiolitis, which was published in JAMA Pediatrics, and his current trial titled FANCY that is ongoing, involving over 14, it's a multi-site trial with over 14 sites. So he is also going to share some of his story. So you'll hear research and narrative together today, and it is such a pleasure to have you here. Welcome to the stage.
Thank you, Kristen, for such a nice introduction. It's a huge pleasure to be here today. My talk is entitled A Non-Traditional Clinician-Scientist Path to Improve Care for Hospitalized Children. And I want to start by acknowledging our lab, the Pitch Lab, which stands for Pragmatic Intervention Trials for Children Hospitalized with Common Conditions. It's these folks that have made a lot of the work that I'll be presenting today possible through their dedication. Our lab manager is Allison Coons, and we have two clinical research coordinators, Nedi Oviebo and Ayas Sahib. Two disclosures up front. Our lab has active funding from the Patient-Centered Outcomes Research Institute and prior funding from the Agency for Healthcare Research and Quality, and I will be discussing findings related to work funded by both organizations. Our objectives today are to discuss a non-traditional clinician-scientist career path, recognize the importance of randomized trials for children hospitalized with common conditions, and identify important trial questions in that same population. So we'll start with this non-traditional clinician-scientist career path, and that's where we'll spend the majority of time today. Before we talk about what I mean by a non-traditional clinician-scientist career path, I think it's helpful to spell out what I have in mind for the traditional career path. Most aspiring clinicians are encouraged to, clinician scientists that is, are encouraged to compete for a K or Career Development Award, which supports the majority of their time in research for about 5 years. It's an opportunity to lay a strong foundation and set oneself up to be competitive for the R-level grants. And the R-level grants allow for larger research projects. And at the end of the day, the goal is generally to try to get multiple Rs to really solidify one's time and resources to support the research that we're so passionate about. One of my objectives today is to emphasize that there are alternative paths. For myself, despite never applying for a K award, my career has gotten to a place of multiple Rs and leading grants totaling more than $15 million in federal funding. But by no means am I opposed to K awards or that traditional path. I think they're actually hugely valuable. And in many ways, I have regrets myself about not going down that traditional path. But one of my messages today is to emphasize that there's a spectrum of a traditional and a less traditional approach. What's most important is that we each take the path that's right for us and utilize our unique skill sets to get where we want to go. In my own experience, there were 4 real key pillars that most supported me on this pathway: curiosity, resilience, mentorship, and opportunity. And I'll go through each of those now in turn, starting with curiosity. In my case, it was really a stubborn curiosity that's been fundamental on this path, starting with a natural inclination to question everything. As a child, I was a contrarian right away, questioning my parents' social and political beliefs and values, much to their chagrin. On the medical side, when I got there, I gravitated to evidence-based medicine right away. And then in residency, I found myself just questioning all the interventions that we were prescribing to our patients, not questioning in the sense that I didn't think we should do anything for our patients. I just wanted to assure myself that the benefits of what we were doing outweighed the harms. And so that led to spending a lot of afternoons after rounds, like really reading about whatever condition we were treating, trying to go to the primary evidence as much as possible, questioning my attendings at times, maybe too often. And I'll share a couple examples. We were taking care of a patient with osteomyelitis during residency. Um, and I'd learned along the way that there were sites that were not doing PICC lines anymore, at least for uncomplicated osteomyelitis, and sending kids home with oral antibiotic therapy. And there was some decent evidence to support that, especially outside the US. So I presented that to my team, and ultimately, was shut down, like often happens. Maybe not at this institution, but so we sent that patient home with a PICC line. And part of the reason I remember the case so well is that this patient got readmitted on Christmas Day for a PICC line complication. So that really stuck with me. And then another case happened during fellowship. We were treating a patient with GBS bacteremia. And the unique thing about the fellowship that I did, it was a pediatric hospital medicine fellowship before that was an accredited subspecialty, which meant that I wasn't a PGY 4, 5, 6. I was a visiting instructor, like kind of a full attending who could just make whatever decisions I wanted to. And so in the first couple months in fellowship, we had this patient with GBS bacteremia who, defervesced and got better pretty quickly. And again, I had been familiar with some literature suggesting that those patients didn't need PICC lines either, potentially. No one at our institution would do that, but I decided, since I was now the attending, I was going to do that with my resident team. And we did, and everything, was worked out well. I think I actually called this family a couple days later just to say, hey, is your child doing okay? Because I was pretty nervous about stepping outside the box like that. But this attitude of questioning everything, continues to this day. Whenever I'm getting sign out, I'm always sort of thinking in my head, like, oh, that's an interesting way of doing it. I wonder what the evidence is for that. I should really look it up before I go on service tomorrow. Same thing with consultants, trying not to just do whatever the recommendations are without thinking about it. I encourage our team to always ask ourselves, well, what's the evidence behind those recommendations, and think about it critically. The second point here is that my clinical experience has pointed the way as far as the research questions that I tend to tackle. Behind every research question are patients that I've cared for and the uncertainty that I've faced in managing their care. So, for example, building on those prior stories, a couple of years after fellowship, I led a study, a comparative effectiveness study of early oral antibiotics versus prolonged IV antibiotics for kids with GBS bacteremia, influenced by the case I had in fellowship. Similarly, we documented a decline in PICC line rates in another research study for conditions like osteomyelitis. Again, I don't know that I would have been so interested in that without seeing that case in residency. And the third point here is that it's neither possible nor advisable to pursue every single research project on every single patient that makes you a little bit curious. You do have to prioritize. And one of the ways that I try to think about it is focus on those ideas that keep you up at night. Maybe it's because you're so excited to dig into them. Maybe it's because you had a case that was particularly perplexing. But you should, really look for, when it comes time to study that, you should be excited about it. That's the goal. So the next pillar that has been important along this pathway, in my case, is resilience. There's always going to be bumps along the way. And I'll share a couple of mine as well to illustrate that. Again, I did a pediatric hospital medicine fellowship early on, and that was extremely focused on research training. And I think, like most fellowships, one of the early tasks was find a primary research mentor. So I went around meeting with various individuals. I had a great session with one person who was our local expert on PICC lines. And so I got excited about working with that individual, started fleshing out the idea. I presented it at a national fellows conference. I had my 2 or 3 pager, getting the IRB ready. And then I ended up meeting with that person again and learned that the individual was not going to be able to be my primary mentor. I kind of got broken up with, if you will, in the professional sense. And so that took a lot of the wind out of my sails early on in my fellowship. Not only did I need a new mentor, but I kind of needed a new project because there wasn't really anyone else at our institution who was going to be right for that research question. So that was pretty tough to deal with, and I felt kind of lost for a couple of weeks. And I went back to the drawing board and reflected on the patients that I had cared for that I felt the most curious about and maybe got me the most fired up. And I landed on doing a study on video fluoroscopic swallow studies for infants hospitalized with respiratory illness because I had noticed that our institution was doing a lot of swallow studies. And I just found myself thinking, are these patients benefiting from these studies? Because it's non-trivial to tell a family that they're going to have to change the way they feed their infant. And so I was very curious about it and went down that particular study path and had a successful experience. Another bump along the way happened near the end of fellowship. I had written a few papers and I was loving my Master's of Science in Clinical Investigation. I took a grant writing course and I started to realize, I really like research, and if I want to keep doing it, I probably need to get a grant. There wasn't a lot of pressure on me from external forces, but it just seemed like a logical step. So I decided to submit for an internal grant mechanism. It was a staged mechanism where you submit a concept idea, and then if that can be accepted, you go to a grant writing course where you refine your idea and then ultimately submit a full proposal for consideration of funding. So I submitted my idea. I was accepted to the grant writing course, which was in this idyllic mountain town near the hospital. And it was a weekend long thing. I found myself meeting with the leader of the grant writing workshop, who also would be the one to really decide what was going to be funded. And she gave me some feedback, and then it ended with this person telling me that my idea wasn't fundable. Like I was invited to the grant writing workshop to work on my grant writing skills, but there was no interest in the actual idea, and there probably wouldn't be. And so I was admittedly fairly immature, I would say, like professionally at that point, and took the feedback maybe a little bit hard. And that experience, along with a few others, really led me to think maybe grant writing is not for me. And because one of my fears was that it was really important to me to focus on research that I was excited about. And I was worried that if I went down a grant writing path, I'd have to change my idea to make it more fundable, such that it might not be recognizable anymore or wouldn't be what I was most excited about. And that experience kind of reinforced that fear for me. So I stepped away from grant writing for a couple years, actually. But again, this is about resilience. And ultimately, I did get on that pathway, and I'll tell you a little bit about how I got there. I think in order for us to find our way in the face of whatever bumps come along, it's critical that we keep those who inspire us close. And that can be family, friends, colleagues, mentors. I'll talk about now a mentor for me who's been extremely impactful, someone who has helped me overcome the obstacles in my career as a mentor is Alan Schroeder. For those of you who don't know him, he is a hospitalist and intensivist, clinician-scientist at Stanford. No one has had a larger influence on my career and the research that I pursue than Alan. He showed me that you can be successful while doggedly following your own curiosity. Just to give you the backstory on how we started working together, our paths first crossed around the time that my local mentor fell through. I reached out to Alan through a mutual acquaintance. I had been an admirer of his work for some time. He and Tom Newman published this paper about safely doing less. I remember reading that in residency and just it really spoke to me. So we started working together. It wasn't ideal that we were at different institutions, particularly while I was so junior, but we made it work. And within no time, we were working on a paper describing overdiagnosis in pediatrics, which turned out to really help my career. But I think most importantly, by working with Alan, I rediscovered my passion for research. We've since written numerous papers and grants together and really forged a lifetime bond. He came to my wedding, for example, and he remains my most closest collaborator. The fourth pillar that I'll talk about is opportunity. And by opportunity, I also sort of mean support and perhaps sometimes some good fortune. One of my first division heads told me early on in fellowship that a once in a lifetime opportunity comes along every few months. And I think what he meant maybe many things by that, but the way I interpreted it was opportunities abound, and sometimes it's just a matter of being open to them. And I'll again share a few examples in my career where opportunity has manifested itself. The first has to do with non-clinical time early on in my training. One of the main reasons that I did a fellowship was to have time away from the clinical side to focus on research and research skills. And one of the main reasons I chose to go to Utah actually was that their fellowship at the time was really focused on giving folks time to do research, do a master's of science in clinical investigation. So it was very intentional to seek out that non-clinical time early. And then I was afforded some non-clinical time early in the first few years out of fellowship, which allowed me to develop some of my own research ideas, do projects on a shoestring budget, you know, cleaning my own data, using Stata to do the analysis myself, kind of a one-stop shop that didn't require any funding. But ultimately that, you know, led to larger external funding. The second opportunity happened around COVID pandemic, actually. In pediatric hospital medicine, like I think a lot of places of care, we had way fewer patients than ever before that spring of 2020, such that our division head was canceling some of our shifts, myself included. I was told, oh, you don't need to come in next week because we only need 4 hospitalists instead of 5 or 6. And then, of course, people were hunkering down. We weren't seeing our friends and family as much or traveling. And I'd been sort of batting around this RO1 idea at the end of 2019, the fall of 2019, and sort of came to the conclusion, maybe this is the time that I should really go after it hard and get it across the line, given that I suddenly have some extra time on my hands. So that's what I did. I didn't really realize what I was getting into. It turned out it was several weeks of not leaving the house and that sort of thing. But we got it submitted. And I have since realized like that's a great accomplishment. We should always celebrate when we just submit a grant, you know, step one. That grant was not funded. It was discussed and scored. And then ultimately it got funded on the resubmission. And that was, of course, a huge breakthrough in this non-traditional path. All right, now I'm going to shift gears a bit to talk about the trial that Kristen mentioned earlier. Some of the research that I'm doing as a non-traditional clinician scientist, and actually talk about 3 randomized trials that I've led or I'm leading, starting with this one, the bronchiolitis follow-up intervention trial, or BENEFIT for short. We randomized children hospitalized with bronchiolitis at 4 hospitals, 2 in Utah, 2 in California, to 2 different post-hospitalization follow-up strategies. The first was automatic follow-up, where we instruct families, schedule a visit with your regular doctor before you leave the hospital and have that visit within 7 days, no matter what. Versus as needed follow-up, where we instruct families to not schedule the visit as they're leaving the hospital, but rather follow their child's symptoms at home. If they get better, like a lot of kids with bronchiolitis do, they don't have to have their post-hospitalization follow-up visit. But of course, if they get worse or the parents become concerned about something, make an appointment to see their primary care provider. And what I like about starting with this trial is that it does embody those pillars that I was just talking about. You know, from a curiosity standpoint, follow-up is an intervention that we do all the time as pediatric hospitalists. I'm not sure how it is here, but everywhere else I've been, it's kind of a knee-jerk thing. We think to ourselves, absolutely, a child's been sick enough to be hospitalized. Why wouldn't they go see their primary care provider in a few days? What could be bad about that? But at the end of the day, we don't really know if it's necessary, and there may be harms. That's the exact type of thing that I love to study, things we've taken for granted that we don't have great evidence behind. Simple things often. From a mentorship standpoint, Alan and I were co-principal investigators on this project. We first discussed the idea at a PAS in Baltimore. We were doing a jog together around the waterfront there. And it was a mentor-mentee jog, you know, talking about life things, but also research. And that's where this idea first came out. And we weren't planning to do it necessarily until an opportunity came along, which was an announcement for a Stanford Intermountain Collaboration Grant, just kind of a small partnership between those two entities, which seemed tailor-made for us because he was at Stanford, I was in Utah. You had to have a PI from each institution. And we'd been working together. We had this idea. So that just fell right into place, and got me on this back on the grant writing path after several years off of it. From a resilience standpoint, that came into play because they were only going to give us $75,000. Like that was the max amount of money for the grant, which is great, but it's not a lot of money to do a multi-center randomized trial. So that meant that Alan and I had to not just be co-PIs, but also, project managers, data managers, sometimes the clinical research coordinator. For example, I built our REDCap data collection instrument. We both approached and enrolled a lot of the patients who actually participated in the trial. We made some of the follow-up data collection calls ourselves. I cleaned our data set, ran the analyses. We just put a lot of work into this trial to make it succeed. Now, of course, I'm, as I already said, super curious about this research question, but that doesn't mean you should naturally be. So, why should you or anyone else care about this research question? First point I would make is that there are 20 million pediatric follow-up visits in this country each year. The vast majority are not for post-hospitalization follow-up, but whatever we learn in the setting of post-hospitalization follow-up may have some generalizability to these settings in this big bucket of care. Secondly, it's been proposed as a quality metric, automatic follow-up, that is, such that it's a common target of quality improvement projects. Like, how can we make sure that our patients have their visits scheduled before they leave the hospital and go to those visits? Again, we don't know if that's beneficial. And then thirdly, I think as clinicians, we tend to underestimate the burden that these visits might place on families. While their child's hospitalized, the parents have had to take time away from work and other responsibilities. Now we're saying, congratulations, you get to go home, but we want you to take a little more time away from work in a couple days. Transportation can be an issue, particularly for families that live rurally. There's copays and other out-of-pocket expenses associated with getting to these visits. And lastly, there is a risk of overtreatment. Other studies have shown that when children have extra visits like these, they sometimes get interventions prescribed to them that they didn't need and that are not evidence-based. These are our findings from Benefit, starting on that first row there, attendance of a follow-up visit, the proportion of families that chose to go to a visit within 7 days of discharge. You can see that 19% in the as-needed follow-up group decided they wanted to go to a visit and attended versus 81% in the automatic follow-up group. We were pretty pleased with that spread because at the end of the day, these families could do whatever they wanted. We were just giving them a recommendation for either as-needed or automatic follow-up. Certainly the as-needed follow-up percentage, it shouldn't be zero. Some of these families should decide they need a visit and attend. And then our primary outcome was parent anxiety, asking the question, does a recommendation and perhaps attendance of a automatic follow-up visit reduce a parent's anxiety within 7 days of hospital discharge? We did not find a difference for our primary outcome, nor any of the secondary or exploratory outcomes, a couple of which are listed here: time to symptom resolution and hospital readmission. We concluded that as-needed follow-up is non-inferior to automatic follow-up, and given the reduced burdens on families in the healthcare system by doing as-needed follow-up, concluded that as-needed follow-up is probably a reasonable default for most otherwise healthy children with bronchiolitis. All right, so let's return to this slide. And it's 2019. I've just finished working on Benefit with Alan. So I'm about 4 years out of fellowship, and I've learned something really important. I loved being able to do a randomized trial to answer a research question, and I actually really like grant writing, which was a real gift at the time. So, it was obvious then that if I wanted to keep doing trials, I would need to write more grants. And I was faced with this critical decision point. Should I go try to get a K award or an R? It was an awkward position because I was 4 years out of fellowship and you could kind of make an argument for either way. And so I sought counsel from many folks and ultimately decided to start with the R and then potentially return to the K approach if necessary, because I was less interested in further career development at the time. Not that I wouldn't love to just, take classes for the rest of my life, frankly, but I was most excited about trying to do more trials. And to do multi-center trials, you typically need those R-level grants, which allow for, larger and more complex study designs. And so this is the R01 that I submitted during that COVID time period that I was referring to before, called the Follow-Up Automatically versus As Needed Comparison, or FANCY trial. In this trial, it's very similar to BENEFIT. As you'll see, we expanded beyond bronchiolitis to 4 other really common infections that lead to pediatric hospitalization: pneumonia, urinary tract infection, skin and soft tissue infection, and gastroenteritis. And then we randomized them to those same 2 interventions, either automatic or as needed follow-up. This is actually an ongoing grant. We are just about to finish year 3 out of year 5. And I think you can tell that findings from BENEFIT and that experience that we got leading a multi-center trial were hugely instrumental in being able to compete for funding to do FANCY. And of course, I want to acknowledge Kristen Ray, who's a co-investigator on this project. It's been a ton of fun to work with her and learn from her as part of this team. This is a conceptual overview of FANCY. These decisions about post-hospitalization follow-up always involve 3 different groups of folks: hospitalists, or the inpatient team, the patient and their family, and the primary care provider. And there are these contextual factors that come into play and influence decisions about whether to do automatic or as needed follow-up outside of a trial, and influence the success of each of those interventions. Aim 1 of FANCY is really focused on effectiveness. And our primary outcome is hospital readmission. Other secondary and exploratory outcomes are related to patient and family-centered outcomes, things like time away from work, child quality of life, et cetera. And then we are also measuring continuity of care with the child's primary care provider, because it's possible that as needed follow-up might disrupt that relationship between the family and their PCP. So we're looking at things like well-child checks 6 months after discharge and immunizations received 6 months after discharge. Aim 2 focuses on being able to be set up to implement whatever our findings are. Maybe it's that as needed follow-up is effective and the way to go. Maybe it's automatic follow-up. Obviously, we don't know until we finish the trial. But we're trying to understand how those contextual factors influence appropriateness, acceptability, feasibility of as needed and automatic follow-up. These are the 8 main sites across 8 states that are participating in FANCY, 14 total hospitals, because several of these sites have 2 hospitals that are participating, often a children's hospital and a community hospital. Here's where we are in terms of our actual enrollment in FANCY. Along the y-axis are the number of participants who've been randomized to date, and then time since the trial started is along the x-axis. The dashed orange is our target enrollment, and blue is actual. So you can see that we're a bit ahead of schedule, about 3 months ahead of schedule, which we feel great about. And we've randomized about 1,800 patients, which, as far as we know, makes us one of the largest patient-level trials in pediatric hospital medicine history. So I'll transition now to our most recently funded pragmatic trial that I'm leading with Chris Bonafide at Children's Hospital of Philadelphia. It's called the I Decide After a Bronchiolitis Hospitalization trial. This project also builds on BENEFIT with a goal of increasing as needed follow-up, specifically for children with bronchiolitis, because that's where the evidence is at this point. And we're doing it in a real-world setting across 30 hospitals. So it has a dissemination and implementation focus. The dissemination and implementation question is comparative effectiveness of a moderate resource versus a high resource implementation strategy. Ultimately, we expect that both of these will increase as needed follow-up across all these hospitals. But what we're really getting at is understanding whether the high resource strategy is substantially better than the moderate resource strategy to warrant that increased investment. This is a 5-year grant, and it'll be starting this April. again, I think we should always ask this of our research questions for ourselves and for others. Why should anyone care about this particular question? First, 17% of all hospitalizations for children under the age of 2 years are bronchiolitis. So this is an extremely common condition. Secondly, the evidence and expert opinion now favor as-needed follow-up as a default for this population. Yet only 20% of children hospitalized with bronchiolitis are receiving as-needed follow-up recommendations, and 2/3 of them are attending post-hospitalization follow-up visits. So there's a bit of a disconnect there. And our prior work would suggest that a good portion of those visits that are being attended are unnecessary for the family and the healthcare system. And then over-medicalization probably burdens families. Multiple studies have shown that children with bronchiolitis who have follow-up are prescribed medications that are discordant with national guidelines: antibiotics, albuterol, steroids. These are the components of the moderate resource strategy to which hospitals can be randomized. There's educational outreach, which includes family-facing handouts and clinician-facing items like slide decks. Second component of the moderate resource strategy is audit and feedback, where sites see dashboards of their as-needed follow-up prescribing in near real time, and that's stratified by important patient demographic characteristics. The third component is an electronic health record clinical decision support toolkit, where sites have resources to integrate as-needed follow-up, discharge order sets, and instructions into their EHR. And then the high resource strategy builds on the moderate resource strategy. Same 3 initial components and then 2 new components related to facilitation. The first is small group facilitation, where site PIs meet with our implementation science core on a monthly basis and focus on collaborative problem solving with other site PIs. And then there's expert CDS coach-led facilitation, in which electronic health record expert coaches are paired with the site PIs to really help them dig in and overcome those EHR barriers to fully integrate as-needed follow-up into their workflow. These are the aims and hypotheses of IDECIDE. The first aim is to examine the effect of a moderate versus high resource strategy on as-needed follow-up prescribing and follow-up visit attendance. We hypothesize that high resource hospitals will more often prescribe as-needed follow-up, and their patients and families will less often attend post-hospitalization follow-up visits. Second aim is to measure the effect of as-needed follow-up prescribing on patient outcomes. And we hypothesize here that compared to families prescribed automatic follow-up, families prescribed as-needed follow-up will experience improved patient and family-centered outcomes. Decreased time away from work and other responsibilities, decreased overtreatment, but no change in needed care, things like immunizations and well-child checks, and no change in readmission. Aim 3 seeks to identify mechanisms linked to adoption and sustainment of as-needed follow-up. We hypothesize that the high resource strategy will result in better hospital-level sustainment of as-needed follow-up because facilitation will increase intrinsic motivation, routinization, and institutionalization. So that concludes my non-traditional clinician-scientist career path and some of the trials that I'm working on. And I'd now like to talk a bit about why I think randomized trials are so important for children hospitalized with common conditions. First, as I think everyone knows, randomized trials are near the top of that evidence pyramid. Really, the only thing higher than the randomized trial is a systematic review and meta-analysis of randomized trials. They're the highest quality evidence and the least risk of bias. The principal way that randomized trials reduce bias is through randomization. A flip of a coin determines treatment assignment. Neither the patient nor the provider gets to decide which group they're in, and that removes a lot of bias. It's very different from observational studies where a patient's preferences, beliefs, their health status may influence which treatment they receive. That coin flip ensures that the groups are nearly balanced for both measured and unmeasured confounding. As a result, RCTs are generally the definitive design to determine efficacy and effectiveness. But of course, there are reasons that more trials are not done. They're very complicated and costly. They require a lot of resources to do, but the danger of never doing trials is that we don't know the extent to which patients are benefiting or not from those everyday interventions that we are prescribing. This is one of my favorite examples of that point. It comes from adult medical world. It's an older study now. At the time that the investigators were planning this study, it was known that adults who suffered myocardial infarction were very vulnerable in those first days, weeks, months after their MI, vulnerable to subsequent morbidity and mortality. And it was known that PVCs would contribute to that, and that there were these medications that controlled or reduced PVCs. So it was really logical to start prescribing patients those medications. We know that the PVCs are causing bad things. We can prescribe medications that control the PVCs. And it kind of became the standard of care, despite not having big trial data out there to support it. These investigators came along and decided to do this trial called CAST. They actually had trouble with recruitment initially because providers felt like it was unethical to let their patients participate. They were and get randomized to placebo. They were that confident that these medications were effective. But the investigators persevered, finished the trial, and it turned out that these drugs, compared to placebo, increased the risk of death threefold. So it was a huge, shocking finding and led to obviously no longer using those medications in that way. And I think this is an example of a very well-intended intervention, a very logical intervention that turned out to be pretty harmful. And I share this, I don't know that there are examples quite this stark in pediatrics, but I am confident that some of the interventions that we're using, at least in hospital medicine on a daily basis, if we were to do a randomized trial, we would learn that patients aren't benefiting, even though it's super logical that they would be, and we assume they are, and they might be being harmed. So for that reason, I think it's really important that we figure out how to do more trials, particularly, my bias is for children hospitalized with common conditions. The field that I'm in, pediatric hospital medicine, we, I think, are the experts in the clinical care of this population, but we're a really young field. We've only recently been accredited as an official subspecialty. Most investigators in our field are very junior, mid-career at the most, oftentimes. So we haven't had a chance to do a lot of trials. And that I see that when I'm on service. It's really rare to be able to turn to randomized trial data to guide those everyday decisions that I'm making. And if there is a randomized trial, there's usually only one. So that takes us to our third objective today. We need more trials. One step in the right direction is to identify important trial questions for children hospitalized with common conditions. And I've had the great pleasure to work with Suni Kaiser at UCSF to lead an ARC-funded R13 conference series called Developing an RCT Agenda for Children Hospitalized with Common Conditions. Our first aim was to identify and prioritize trial questions in this population. The second aim was to identify facilitators to community hospitals participating in randomized trials. We accomplished those aims through a series of conferences spanning more than 1 year. A total of 46 individuals from 30 different institutions participated in our conference series. We successfully recruited parents of hospitalized children, children's hospital and community hospital pediatricians, other clinicians like nurses and pharmacists, biostatisticians, trialists, and had a nice variety of specialties represented: hospital medicine, general pediatrics, emergency medicine, infectious disease, and critical care. During the pre-conference phase, our first task in identifying trial questions for common conditions was knowing what are the most common conditions that lead to hospitalization for children. We used publicly available data from ARC to ascertain that. Far and away, the most common reason for pediatric hospitalization is a child's birth hospitalization, followed by common respiratory illnesses, bronchiolitis, pneumonia, and asthma. These are the 10 conditions upon which we focused our trial question generation. After identifying those common conditions, a medical librarian performed structured literature searches to pull guidelines and systematic reviews for each condition. Small groups of conference participants then used resources to identify evidence gaps and generate potential trial questions for each condition. During Conference 1, participants discussed the importance of each trial question generated by the small groups in the pre-conference phase, and then anonymously, individually scored questions by importance. We then had an interconference period where trial questions from Conference 1 were distributed across a national listserv, and we sought public commentary. And then Conference 2, scores for importance and from Conference 1 were reviewed, and comments from the listserv. And then the conference participants discussed the feasibility of each randomized trial question. In Conference 2, we finished with participants anonymously, individually scoring the questions by both importance and feasibility. And ultimately, we generated 63 randomized trial questions. These are the top 4 most important and feasible questions that came out of the conference, all focusing on antibiotic therapy for common infections. Starting with children hospitalized with cellulitis, comparison of treatment failure rates for those randomized to a short course versus a longer course of antibiotics. Among children hospitalized for pneumonia and medical complexity, looking at rates of clinical deterioration for those randomized to narrow spectrum versus broad spectrum antibiotics. Among children hospitalized for urinary tract infection, comparing treatment failure rates for those randomized to shorter versus longer courses of antibiotics. And then for children hospitalized with pneumonia and otherwise healthy, comparison of oral antibiotics from the beginning of their hospitalization versus IV antibiotics from the beginning of their hospitalization. And what I find really fulfilling about this project is that there are pending or submitted grants for all 4 of these questions. So I think that means that our conference findings are really influencing the research agenda in our field. The last part of that conference was the goal was to identify strategies and solutions for successfully conducting trials in community hospitals. And this is really important because the majority of children in this country are still cared for in community hospitals, particularly children with common conditions, but very little research happens in that setting. We conducted 2 rounds of consensus building using something called a nominal group technique. Round 1 began with individuals brainstorming around a prompt, which was strategies and solutions for successfully conducting pediatric trials in community hospitals. Step 2 involved sharing and recording of the ideas, and then discussion and refinement of the ideas, still in those small groups, finishing with individual rating at the end of round 1. And then round 2 was all in a large group setting. We took the highest scoring strategies from round 1, discussed those in the large group setting, and then finished again with individual rating to find out what are the most critical strategies for conducting trials in community hospitals. And this is where we landed. The strategies fit into 3 different buckets: policy changes, centralized resources, research design. I'll just highlight the top 3 here. From a policy standpoint, encouraging organizations to prioritize funding for pediatric studies that include community hospitals specifically. In terms of centralized resources, encouraging infrastructure for core study procedures, like maybe a national data coordinating center. From the research design standpoint, focusing on hospital level or cluster randomized designs, and other ideas that ease the recruitment burden and consent processes for community hospitals. All right, we've reached the final couple of slides here. To summarize, there's more than one way to become a clinician scientist. As I emphasized earlier, I think there's a spectrum of traditional and less traditional approaches to all the work that we do. And what's most important is that you take the path that's right for you and utilize your unique skill set to get where you want to go. For me, curiosity, resilience, mentorship, opportunity were fundamental, but like the journey, I think the skill set is also very unique to the individual. And finally, if we're going to deliver the best possible care to children hospitalized with common conditions and make sure that we're maximizing benefit, minimizing harm, we need more randomized trials. And I know we can get there. All right, thank you for listening to this talk. Thank you for hosting me. It's been a real joy to be here and learn about all the great things that you all are doing. I'd love to hear all your questions, comments, musings, etc. Thank you.